Good evening, friends. Today I've come up with a new topic and a very important topic, both from the exam point of view as well as practical point of view. Polyhydramnios. I'll be talking on etiology, diagnosis, and management. I can see that only few PGs have joined in now, but I would start not to waste the time. And PGs must be thinking that anyway it will come on YouTube. Why should we waste the time now? But let me tell you something. That thought itself will make you lazy, that you will think that I will see sometime and you will never see that. So instead of that, I would prefer you to log in as much as possible. I know that there are only 100 seats, but it is always better to listen to me live. And of course, it also will make you forcefully learn the topic. So without wasting much time, let me straight away jump into the definition. The qualitative definition is excessive volume of amniotic fluid. Everyone knows that. The word poly suggests that. But then you have to have a quantitative definition as well. Clinically, symphysiofundal height more than 3 centimeters of period of gestation is considered polyhydramnios as per BMC Pregnancy Childbirth 2019 article. Ultrasound-wise, the most popular method of assessing the fluid is amniotic fluid index, and that probably is better. I will shortly tell you why it is better. AFI more than 24 centimeters is considered polyhydramnios. If you want to do single deep pocket, sometimes it is called single vertical pocket. I'm going to use the word SDP in future. If it is more than 8 centimeters, then it is polyhydramnios. I hope these things are very clear now. What is the incidence? Fortunately, it is not that common. It's only 1 to 2% in general population, which may include GDM, may not include GDM. But if you take only the diabetic population, it may be more. Okay. So reported rates are highly influenced by gestational age. Obviously, it is higher in preterm, lower in post-term. Of course, at term, it comes down to around 1 liter. We all know that. And after term, it drastically comes down. Population studied also influences, for example, whether you are studying low or high risk patients. High risk, if it includes GDM, then obviously the incidence is high. Screening or indicated ultrasound, antepartum or intrapartum. Obviously, intrapartum, the liker will be less. What is the diagnostic criteria used? That's what I was trying to tell in the previous slide. If you use SDP as your diagnostic criteria, there's a slight difference. And if you use AFI as the criteria, there is a slight difference. Let's see what it is. If you use SDP as the criteria, there is a tendency to overdiagnose polyhydramnios. Obviously, because in SDP, you are looking at one single pocket, and by chance, that single pocket can be more than 8 centimeters. But that may not happen in all the other quadrants or all the other areas. That's why there's a chance of overdiagnosis if you use SDP. But AFI also has a drawback. If you use AFI, there's a chance to overdiagnose oligohydramnios because you are looking at 4 different quadrants at the vertical. There's a method to use the transducer like that. And then there's a chance that you may catch less liker by this method. So there's a chance of overdiagnosis of oligohydramnios. Both are having their own drawbacks. So you may use both if you are in doubt with regards to either polyhydramnios or oligohydramnios. What is a pathogenesis? It's a no-brainer. It's been put in 1965 article itself, as you can see there. Amniotic fluid volume actually reflects the balance between the fluid production and movement of fluid out of amniotic sac. Obviously, it is production and the movement outside the sac. Most common mechanisms are decreased fetal swallowing. See, baby produces the amniotic fluid. Also, it contributes to produce amniotic fluid, both the membranes, the baby, urination, everything. At the same time, baby swallows also. So if there is a decreased fetal swallowing, obviously there will be polyhydramnios. And increased urination. As I just now told you, there is a contribution from the baby in the form of urination. So it keeps on urinating, but decreases swallowing, then there is a problem, imbalance. Then there is homeostatic mechanism. That means intramembranous absorption. It's not just swallowing by the baby, there's an intramembranous absorption also. That means transfer of amniotic fluid across the amnion into fetal circulation. This basically works to maintain the amniotic fluid volume in general and more successful in preventing poly rather than oligohydramnios. Because in oligohydramnios, there is no production only. So there's no question of the membranous absorption trying to hit a balance. Whereas in polyhydramnios, if the absorption occurs properly, that prevents the polyhydramnios. That's the meaning of it. What are the conditions that give rise to polyhydramnios or conditions associated with polyhydramnios? It's idiopathic in 40%. Having said that, after birth, abnormalities found in 25% of this 40%. That means in total 10%, you can still make out the problem or abnormality. Finally, 30% remains idiopathic, whether before birth or after birth. The fetal structural anomaly that impedes swallowing. Basically, as you saw, it is increased production or decreased swallowing. So the structural anomaly that impedes swallowing contributes 30% for the polyhydramnios in singleton pregnancies. For example, primary GI obstruction in the form of esophageal or duodenal atresia. Baby may swallow, but it is because of atresia, it may again come back. It will not go into the system of the baby. Secondary GI obstruction, for example, congenital diaphragmatic hernia, cervical or thoracic mass, which will impede the baby to swallow. It is secondary. It's not primary GI, but from outside, it will impede the GI. Craniofacial abnormalities, for example, cleft lip palate, facial tumors, oropharyngeal teratoma is the classical example, and micrognathia. These are the ones which will not allow the baby to swallow properly. So 30% of the problem. So idiopathic is 30% and structural anomaly 30%. Rest of it may be 30%. That is fetal neuromuscular disorders that impede swallowing. For example, myotonic dystrophy, anencephaly. This is the classical. Earlier, when we used to say anencephaly, there are 3 reasons for polyhydramnios in anencephaly. One is the swallowing reflex because of neuromuscular dystrophy. There may be also the regurgitation, and then there may be contribution to the polyhydramnios. And the CSF leak is also one of the reasons. Genetic syndromes. Now, this is very, very important in the formation of polyhydramnios, especially aneuploidies. Now, how we will see shortly in the subsequent slides. Prader-Willi or Batter, and there is Beckwith-Wiedemann syndromes, and then rasopathy, which examples of this are Noonan syndrome, cardiofacciocutaneous syndrome, Costello syndrome. There are lots of syndromes in fetal medicine. Those who feel that we don't have many syndromes in OBG, it's all in medicine. We have some syndromes here, but I refuse to remember them, most of them. But you should know that genetic syndromes can give rise to a lot of fetal problems, whether it is oligohydramnios or polyhydramnios. You have to be very careful. One should not be considered with the other. High fetal cardiac output state contributes a lot. Obviously, when there is high cardiac output, there will be good renal perfusion and there will be a lot of urination. So supraventricular tachycardia, anything that causes severe anemia, example, autoimmunization, viral infection, parvovirus is notorious in that, B19, cytomegalovirus, or hemoglobinopathy, where there is destruction of RBCs and then there is anemia. And obviously, heart is made to work harder and push more blood. There is increased fetal cardiac output. Fetal or placental mass with arteriovenous shunt, for example, sacrococcygeal teratoma or large chorioangiomas. I'm not talking about TTTS yet. It is just in the placenta itself, there is arteriovenous shunts. Twin-to-twin transfusion is a separate entity. That's why I said the earlier point should not be mistaken with this. Twin-to-twin, all of us know, between the placentae, there will be arteriovenous, veno-venous, arterio shunts, and these are the ones which will give rise to oligopoly sequence in the twins. Maternal diabetes. This is the first thing actually that comes to anybody's mind, PG or a consultant. Whenever you come across a case of polyhydramnios, the first thing that comes to our mind is actually maternal diabetes. But that is only one of the many, many things which I've explained. So that's why these last 3 slides are very important for PGs to put a nice, causes of polyhydramnios. So maternal diabetes with macrosomia is more likely to have polyhydramnios, and it varies from somewhere 8 to 22%. I'm going to explain that further, in which exactly type of diabetes there will be more polyhydramnios. Then finally, hydrops fetalis, due to any reason, whether it is RHIS immunization or non-immunological hydrops fetalis, there is a tendency for polyhydramnios. Basically, there are some cardiac output problems or neurological problems or any structural anomalies in the fetus. I was telling you, not all diabetic conditions will have uniform way of polyhydramnios. As you can see in this slide, the rate varied by the type of diabetes. If it is GDM A1, that is fasting less than 105, the incidence is very low, 5.4 only. When it is A2, when the fasting is more than 105, it is 13.4. And when it is type 2 diabetes, it is 15.3, and type 1, which is totally insulin dependent. As you can see here, as the insulin requirement increases, the tendency for polyhydramnios also increases, right? So type 1 is 21.2%. It is the highest. All of these were higher when diagnosed by SDP, which I told you right in the beginning. SDP, that is single deep pocket, has a tendency to overdiagnose polyhydramnios. When you use amniotic fluid index, maybe the incidence will come down. Fetal hyperglycemia induced polyuria, that is osmotic diuresis, is very, very obvious. When the mother has hyperglycemia, it is transferred to fetus. Fetus has hyperglycemia, and we all know polyuria in diabetic patients. The same thing happens for the fetus, and fetus will overproduce. Here, the problem is not that of decreased swallowing. It is the problem of increased production and not maintaining the balance. The amniotic sac absorption is not very effective in this particular patient. So net result is polyhydramnios. Polyhydramnios is often associated with HbA1c levels and fetal macrosomia. The more the HbA1c levels and the more macrosomia, there will be more polyhydramnios. In fact, this was my favorite question to the postgraduates. Can you diagnose diabetes or worsening of the diabetes without doing blood sugars? Yes, the answer is, if there is polyhydramnios, if there is macrosomia, that means it is worsening or the condition is not under control. Decreased fetal swallowing or imbalance in water movement between the maternal and fetal compartments in diabetic pregnancies also contribute, in addition to overproduction in the form of polyuria. This is very interesting, aneuploidy and polyhydramnios. The general tendency is to think that whenever there is an anomaly, there will be oligohydramnios. Of course, that is true in case of any renal problems. Anhydramnios is also seen, but not all aneuploidies will have oligohydramnios. There is a possibility of polyhydramnios. Let us see why. An uncommon cause of polyhydramnios, that's what I was just now explaining. Aneuploidy means the first thing that comes to your mind is FGR and then oligohydramnios, but it's an uncommon cause of polyhydramnios. Let's see how. The combination of FGR and polyhydramnios is suggestive of trisomy 18 or Edwards syndrome. Excessive amniotic fluid is related to difficulty in swallowing or to intestinal abnormalities. That is the thing. The chromosomal anomaly will hamper the growth, no doubt. That's why you will get FGR. But FGR does not always mean oligohydramnios. This is what you have to understand clearly. FGR due to preeclampsia will definitely give rise to oligohydramnios. There's no doubt. FGR with an anomaly, which is basically renal anomaly, then there will be oligohydramnios. But FGR with a anomaly that will give rise to intestinal abnormalities or GI abnormalities or swallowing abnormalities will give a peculiar combination or a unique combination of FGR with polyhydramnios. So that is very, very important for all of us to understand. So don't always equate things like anomaly means or aneuploidy means FGR and oligohydramnios. No, there can be polyhydramnios also. Similarly, other aneuploidies like trisomy 21, Down syndrome, is likely related to the duodenal atresia. We all know there are multiple anomalies in Down syndrome. If there is duodenal atresia, that particular Down syndrome will have polyhydramnios, right? So having understood the conditions and the associations and the way to diagnose polyhydramnios, now let us see what are the clinical symptoms. It's not, again, a very difficult thing to guess. In mild cases, when there's a gradual increase in the amniotic fluid over a period of time, there is actually no symptom. That's what, actually, it's a wonderful thing that in 9 months, even though mother gains, the uterus itself becomes almost like 1 kg, but and the baby is another, let's say 3 kgs, and then the fluid altogether some 11 to 12 kgs, but she doesn't feel it because it is a gradual increase over 9 months. If it were sudden increase, then all of us will feel. If we suddenly try to carry a 10 kg weight, it will be very difficult. But over a period of time, if the gradual increase in the weight, it's not felt. Same way, if there is a mild and gradual increase in amniotic fluid, it will remain asymptomatic. However, persistent shortness of breath and uterine irritability with contraction and abdominal discomfort can occur with severe uterine distension. This is a known fact, Stirling's law. When there's a stretch, there will be a contraction, right? So if there's a excessive abdominal stretch or the uterine fundal height increases compressing on the diaphragm, there will be shortness of breath and uterine irritability contraction. Symptoms may be related to mechanical factors from very large uterus and to high amniotic fluid pressure. So this can make lady uncomfortable. There is a classification of polyhydramnios, all of them, that is ACOG, ACR, and Society for Maternal Fetal Medicine, all of them, they are unanimous in this particular classification. It's very important for you to know this classification. We call it mild polyhydramnios. I'm giving both the values here, whether you use single deepest pocket or whether you use amniotic fluid index. If you use single deep pocket, as I told you, it starts after 8 centimeters, 8 to 12. So it is 11.9, 4 centimeters in that range. So that is actually mild polyhydramnios. If you go by amniotic fluid index, anything more than 24, but here it is not just 4 centimeters, it is almost 6 centimeters, 30, right? So that is mild. When it comes to moderate, now here the difference was 4 centimeters. Here the difference is also 4 centimeters. So 12 to 16, they have given 4 centimeters. But here, if you see, they have made it as like from 6, they are little stringent, 5 centimeters. That's moderate. Then anything more than 16 centimeters is severe. So 8 to 12, 12 to 16, and anything more than 16, very easy here. And here, of course, 6 centimeters range, 5 centimeters range, and anything more than 35 centimeters is severe polyhydramnios. Now, diagnosing polyhydramnios or oligohydramnios is one thing, but that doesn't end the issue. In fact, picture Abhi Baki. It's a starting point of the problem. So once you diagnose polyhydramnios or oligohydramnios, you have to evaluate more carefully. The diagnosing of polyhydramnios and oligohydramnios is not very difficult. Even a blind person can diagnose to the extent. But what has caused polyhydramnios? What has caused oligohydramnios? If you browse my oligohydramnios class, there also have stressed what you do after diagnosis is very important, because further management depends upon the cause. For example, if the cause is untreatable, unchangeable, unmodifiable, then you can't do much actually rather than deliver, whether it is oligohydramnios or polyhydramnios. For example, let's say it is a severe case of oligohydramnios due to a severe renal anomaly. No amount of your management or treatment is going to help that patient at all. You may even try infusions and after infusions, but it's not going to improve. Similarly, if the cause is such a gross anomaly in the fetus where the fetus just cannot swallow, if there is a severe atresia and all the things, then the only treatment is delivery and post-delivery surgery of the baby or pediatric surgery. That's going to, no amount of removal of fluid is going to help it. It will relieve the pain of the mother, distress of the mother, but it's not going to help overall. So that is why the post-diagnostic evaluation is very, very important. So for non-hydropic, singleton, and dichorionic twins, because we know in twin-to-twin transfusion, it's a big chapter, it's a big topic. I have taken 3 classes on that. The management is entirely different based on so many other things. Whereas here it is a non-hydropic, that means the baby doesn't have much of problems, let's say, and it is singleton pregnancy, or even if it is twins, it is a dichorionic twins, then detailed medical history to evaluate heritable diseases associated with polyhydramnios. For example, hereditary anemia, alpha thalassemia, G6PD deficiency, or arthrogryposis. These are very important. Of course, you can't help much when the patient is intrauterine, but then you can take your decision based on the severity of anemia in the fetus, okay? Whether to deliver them early or you can manage some more time. Evaluate for fetal hydrops. So this is very important. The first point was non-hydropic singleton, but now you have to actively look for whether there is any fetal hydrops. And if there is fetal hydrops, there's a big list of things that is to be looked after. Please refer to my lecture on hydrops fetalis class. So it could be non-immune or immune. Immune obviously is RHS immunization. Non-immune, there's a big list of things, starting from cranial CNS problems to the respiratory problems to the GA problems to the renal problems and so many other skeletal problems. Evaluate for fetal anomalies. Just now we saw fetal anomalies can give rise to polyhydramnios. 80% of anomalous infants were detected prenatally. Nowadays, with the high resolution ultrasound and expert fetal medicine specialists, anomalies, they just diagnose like this. Maybe with the one eye also they can diagnose, even closed eyes they can diagnose. So post-diagnostic evaluation also include measuring the MCA-PSV, which is a direct marker of fetal anemia. In fact, the sensitivity is 100%. If it is more than 1.5 MOM, workup for immune and non-immune causes of fetal anemia. There is definitely anemia. That's why there is increased velocity in the middle cerebral artery. Offer genetic counseling and fetal genetic studies. You may have to do an amniocentesis for fetal microarray in pregnancies with a congenital anomaly or severe polyhydramnios. This, how does it help? Does it treat? No, it helps in actually counseling the patient, helps in taking further decision, whether to continue with pregnancy, whether to terminate pregnancy. If at all we have to terminate pregnancy, how early we can do or how late we can do. So all these things will become easier if you do this genetic counseling and fetal genetic studies. Screen for maternal diabetes. This is standard. This is no-brainer. Everybody will test. If there is polyhydramnios, diabetes is the first one to be tested. We may not be actually thinking of genetic factors. From today onwards, you will think of genetic studies as well, and you will also think of the Doppler studies via MCA, PSV, and you will take detailed histories and things like that. Torch is an unlikely cause of isolated polyhydramnios, and we do not actually screen for it in Manipal. So Torch is almost lost its battery. What's the outcome of all this? Many idiopathic cases resolve spontaneously. The 30% of the cases where there are no anomalies or no obvious cause, They may resolve spontaneously if it is mild polyhydramnios. However, polyhydramnios has been associated with an increased risk of several adverse outcomes in addition to poor outcomes related to associated fetal morphological abnormalities. So morphological abnormalities are not only the cause, but they also are the reason for adverse outcome. Plus, there are more other adverse outcomes if there is associated polyhydramnios. This is what is the meaning of this particular sentence, and you will soon understand when I go further during the management how, in addition to baby having problem, which is the cause of polyhydramnios itself can cause fetal problems later, either towards the end of pregnancy or in labor. For example, sudden rupture of membranes, abruption, and cord prolapse, and so many other things. Maternal respiratory compromise. Not only the baby, mother also has got this problem, respiratory compromise. There can be pre-labor rupture of membranes, as I just now told you, and preterm birth and preterm baby. So this is in addition to fetus having problem. I hope you are understanding what I'm trying to say. Fetus is having problem, that is a cause of polyhydramnios is one thing. Because of polyhydramnios, there can be PPROM and there will be preterm birth, and that will add to the problem. So there will be two problems on hand. One is preterm baby, other one is preterm baby with a problem, anomaly. Fetal malposition. So when there is polyhydramnios, baby has got a lot of space to swim around. It will suddenly change from vertex to breech to transverse, and all that is a problem. Macrosomia. So polyhydramnios associated or due to diabetes will also give rise to macrosomia. We all know that the root of it, the hyperglycemia of the mother is transferred to the fetus. Fetal hyperglycemia will make the fetal pancreas secrete more insulin, and hyperinsulinemia will make the baby to deposit fat in its shoulders. And macrosomia itself is a problem. It's a potential problem for shoulder dystocia. If you are not diagnose it, then you will be in trouble. 1/3 of all the legal cases in America are due to shoulder dystocia. Umbilical cord prolapse. I have already told you this. If there are premature rupture of membranes, mobile head, and sudden gush of fluid, umbilical cord will come out. That will be the end of the baby. Baby will die unless you are there to immediately take care of the situation. So these complications increase the risk of cesarean birth and admission to NICU. So it's almost like a vicious circle. You don't know which one came first and what caused the problem and how the problem progressed. So fetal and neonatal prognosis obviously depends upon what is the cause of polyhydramnios, how you handled it, and things like that. So it can land up in PPROM, as I said, preterm labor, preterm birth, that will have its own problems. Preterm birth in affected pregnancies also may be caused by iatrogenic interventions. So what happens sometimes, if there is polyhydramnios, you may want to reduce the maternal distress by doing a amniocentesis, and amniocentesis or amnioreduction, what you call, that itself will give rise to the